Okay, I guess this is a good time to start talking about infectious diseases. This is chapter 8 out of 10 chapters for general pathology. If you recall, in chapter 6, we talked about diseases of generally inflammatory nature in regards to antigens, which we inherently have in our body. These were the so-called autoimmune diseases. In chapter 7, we talked about diseases involving mutations of gene that regulate growth, which were neoplastic diseases. Now we'll be talking about diseases due to antigens that are extrinsic to our body, which are generally referred to as infectious diseases. I also would like to say that I enjoy doing this chapter very much, but it's difficult sometimes to tread the fine line between what is important in terms of pathology and what I already know you people will be learning in things like microbiology and immunology. So I absolutely do not have the time or the desire to go over all of the infectious diseases in detail because they will be covered from your microbiology courses or in the sections we do on systemic pathology. So that's why we will be breezing through a lot of things. Another thing I want to warn you about for infectious diseases as an introductory statement is that a lot of these pictures are going to look very busy. They're going to have a lot of charts, a lot of small print, and I'm not too sure how YouTube is going to handle it. I know that my big files will be quite adequate in terms of image resolution, but when YouTube crunches this down, you may have a very hard time seeing things. Nevertheless, I'll keep my big files, and if you really need to see some of this stuff, I know you're going to email me and ask me anyway. So let's start to do the chapter. In fact, let's not start to do the chapter. Let's do something that I usually save at this point in the course called a rant. And I'll try to keep this rant short because I had a nice introduction that took up a lot of time. We're going to talk about AAA. And you know, all of this stuff that I teach you in pathology doesn't make a damn bit of good for you unless you really have to understand what you really have to learn. Now, I can teach you about pathology, but your success as a practitioner will have nothing to do with how well you do on my exams or memorize what I tell you. Your success as a real American doctor with a real license will depend on AAA. And this is something that is known universally in private practice, and you may never have any references to it in regular medical school, so I want to tell you right now. You are going to be successful only if you have AAA. And they're in this order. The first A stands for availability. The second A, which is the second most important thing, stands for affability, or how well you relate to people, how well you are known as a nice guy, so to speak, even if you're a girl. And the third A represents ability. Isn't that amazing? Because you can get the highest score on my exam and be a pathology genius, but if you're not available for consults, or you're not known as being a nice affable guy, and you are only able, which is the third A, you're not going to be very successful. So keep that in mind. Number 1A is availability. Number 2A is affability. Take your referrals out for dinner every now and then. Meet their families. The third A is ability. And believe me, you'll all have that. And that's why it's the least most important. Let's talk about the phylogeny of infectious agents. I guess we could move up or down the evolutionary tree if you want to think of it that way. At the very lowest level, we have classes of infectious agents which don't even have DNA, and those are called prions. Most infections in humans are either viruses or bacteria, so that's why they get the big asterisks. If you want to include fungi, we'll add a third asterisk. But remember, if you really want to be thorough and classify the categories of infectious agents, you have to move up the tree from prions to viruses, including viruses like bacteriophages, plasmids, and transposons, which infect basically other infectious organisms like bacteria and do not affect man themselves, if you want it to be complete. And then we'll have our whole category of bacteria of various types. Then we're going to have our obligate intracellular organisms that can't live except if they're living somewhere in your body or your cell, like chlamydia, rickettsia, mycoplasma. Then we'll have somewhat higher organisms called fungi, which basically can be classified of various types, but from pathology point of view, they're either yeasts or hyphae. And then we'll have these big critters called parasites, which if they are only one cell, they're called protozoans. If they're more than one cell, they're called metazoans. Generally speaking, metazoans and worms are pretty much synonymous. Technically, arthropods have a lot of cells, but they're generally known as ectoparasites, whereas these other two are primarily endo, because the ecto pretty much stay outside, or mostly outside the body. So this is going to be the evolutionary model that we follow. And I hope this next picture here doesn't blow your mind, and I hope you could see it too. So if I can't, I apologize, because there are going to be a few pictures like this. Let's look at some of the properties of these general infectious pathogens. We talked about their taxonomy, going up from viruses to chlamydia to rickettsia to mycoplasma to the higher bacteria to fungi to protozoa to helminths. And these can generally be thought of as evolutionary progression, but as you know, the viruses are just as smart as the helminths in terms of the fact that they've been able to live just as long. And we're talking about more of an anatomic complexity here. Generally speaking, the sizes of infectious particles range from, let's say, 20 nanometers up to 10 meters if you have a 30-foot long worm in your intestine. And we're going to talk about their sites of propagation too. For example, viruses, chlamydia, rickettsia, you can't culture them. They have to live inside of cells. So that's why they call them obligate intracellular. When you get to the mycoplasmas, they can be extracellular, but most common infectious agents like bacteria, fungi, protozoas involve propagation either through skin, mucosa, facultative intracellular, extracellular, and they basically have a very intimate relationship with human cells and human tissue boundaries called mucosa. We're going to give samples of each one, and we're not going to go into the actual specifics of all of these organisms. We just don't have the time. I'm assuming you're going to either get that from micro or get that as you know it, and I am not planning to go into any extensive discussion on each one. So here's some sample species for a virus. I think a good general goal for this chapter would be, if you heard of a disease, you should instantly be able to classify it as whether it's from one of these 6 or 7 categories. Now, you should know polio is a virus. You should know that trachoma is chlamydia. You should know that rickettsia, or Rocky Mountain spotted fever, or typhus fever is rickettsial. You should know that mycoplasma pneumonia is mycoplasma, which is different from bacteria or viruses. You should know, if you hear a disease like cholera, pneumonia, tuberculosis, that these are different types of bacteria. You should know, if you hear a disease like tinnias, thrush, sporotrichosis, histoplasmosis, that these are fungi. You should know giardia, sleeping sickness, Chagas disease are protozoans, so is Kala azar. We'll mention these briefly. And if you hear a worm disease, whether it's a nematode or some other type of worm, like enterobia, filariasis, or trichinosis, you should know that these are helminths. Thank you very much for now.
Well, I guess the best place to start in the discussion of infectious diseases is the lowest part of the evolutionary tree. It's so low in the evolutionary tree, it is a substance which doesn't even have DNA, and they're called prions. And prions are infectious particles. Prion stands for pri and on for a proteinaceous infectious particle. It's a substance that causes a variety of central nervous system diseases, infectious diseases, in both non-humans as well as humans. In non-humans, we hear of BSE, or bovine spongy encephalitis, being in cows and cattle, and there's also diseases in sheep and other animals. And in humans, we hear of CJD, or Creutzfeldt-Jakob disease, formerly called JCD, Jakob-Creutzfeldt disease. It's probably more politically correct to call it CJD, however, because there is another JC virus of the central nervous system we'll talk about a little bit later. Prions are protein particles. You could see here's an exact chemical structure in a diagram. Here's a scanning electron microscope. They have a very specific thing. They somehow can replicate and infect and cause sometimes fatal diseases in humans. Another human disease was called Kuru, and when certain tribes of people were eating and cannibalizing one another, they noticed that there was a wasting disease followed by central nervous system symptoms and death, and that was called Kuru. So in humans, only CJD and Kuru are the common diseases. There's a couple of others. And in cattle, BSE. The bottom line is that microscopically, both BSE in cows as well as Creutzfeldt-Jakob disease in humans has the same appearance. And this is what it looks like. And we're going to blow this thing up and show you that this is a brain. You can see neurons here, and 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 here. The rest of these are glial cells. But the one thing that you notice is that in the myelinated matter, there are these spongy little holes. That's why the BSE, the S stands for spongiosis. It's because the central nervous system takes on a spongy appearance due to the infection by these non-DNA infectious protein particles. That's about all we'll say for the non-DNA form of infectious diseases. Let's move up higher to the next level, viruses. Viruses are pretty small. The very, very largest one is less than half of a micron. If you remember, the diameter of a red cell is 7 microns. So in all practicality, they are not visible to routine microscopy. Sometimes some of their effects are, however, not only just the inflammatory effects, but some of the protein effects may cause certain intranuclear or intracytoplasmic inclusions. Viruses are either DNA or RNA. They have a core around their genome. They are not naked DNA and RNA unless they're unraveling inside your cell. And the core the DNA may be single or double-stranded technically, so that's another way of classifying viruses. And most viruses have a capsid surrounding that core. In fact, they all do, which they call the protein coat. Sometimes, in a little bit higher level of viruses, there's another lipid interface surrounding the protein called an envelope. Most viruses have a fairly limited number of genes coding for all the necessary proteins they need to do their pathogenicity thing. And if you remember with the AIDS virus, there's probably less than 20 common genes that have names that code for common antigens common expressions of that in terms of protein structure or function in the virus itself. There is no consistent naming system for viruses. I'm sure someday there will be, and we'll all have to learn a new nomenclature, but for now we have to go by the old system, and they generally are not logical. So practically speaking, in pathology, the best way to classify viruses is by system. So we talk about respiratory viruses, or digestive viruses, or skin eruptions, or perhaps hematologic viral disorders, or arboviruses and hemorrhagic fevers, warty viruses, central nervous system viruses. Those are the common classifications of viruses. And let's start out with respiratory. Now, once again, we're not going to go into the actual full pathogenicity of all these diseases. We're going to talk about things that you should generally know in a casual kind of a way. And when we get to the actual systems, we may very well go into these in greater detail. Here are the common names for the viruses here on the left in red. These are the actual taxonomic viral names. This tells you whether it's single or double-stranded DNA or RNA. These are things you probably don't really need to know. But what you should know is that the general category, or the generic name for viruses, you should know the general category of diseases that they cause. For example, adenoviruses you should think of as being associated with respiratory tract infections, both upper as well as lower, which is lung. Conjunctivitis, diarrhea, rhinoviruses, probably the single most likely virus to cause the common cold. Coxsackie viruses involved in a whole bunch of situations. For example, pleurodynia, herpangina, which is a form of upper respiratory infection, hand, foot, and mouth disease in humans, which is not at all related to the cattle hoof and mouth disease. And I'm not too sure if SARS really should be on this list. I think SARS would probably more likely and correctly be part of the coronaviruses, which is a upper respiratory infection. You remember there was a SARS infection in China a few years ago, which was very scary, and some people died. You should know that the influenza viruses are the single biggest cause of pneumonias in adults, and respiratory syncytial viruses are a very, very common cause for a bronchitis, a bronchiolitis, and extension of that, a pneumonia, chiefly in children. So if you can kind of associate the common name here on the left in red with the general categories of diseases they cause, we'll kind of think of those as viruses, and we won't go into them in too much detail right now. Digestive viruses, well, mumps, which is technically paramyxoviridae, is a single-stranded RNA, causes mumps. Mumps is a parotitis, that's digestive gland, isn't it? Also pancreatitis and orchitis. Rotavirus, probably #1 cause of viral diarrhea. Norwalk agent, another gastroenteritis. And then we have our whole family of hepatitis viruses, which certainly apply for the digestive system as well. Please note that whether you're talking about hepatitis A, B, C, D, or E, they are not at all in the same taxonomic classification. They're all different viruses. Most of them are RNA. Hepatitis B is DNA. Most of them are single-stranded. Hepatitis B is double-stranded. But notice they all express a pattern of acute or chronic hepatitis, and they all have a completely different type of clinical behavior. Well, I just got the beep that I'll have the 1 minute more warning. So let's go continue with the skin viruses in the next block. And I think
probably the best way to classify viruses is using this systems or systemic approach, because it seems to be the only one that's logical. Because on the one hand, we have names of viruses here which almost never correspond to their precise taxonomic name, even though they may seem to. You might think that a parvovirus is part of the parvovirus actual name, but actually it's parvoviridae. So I think that the systemic classification is good. I think it's nice to know that they're generally either double-stranded DNA, sometimes single-stranded, or single or double-stranded RNA. Now in the skin family, these are common viruses we have heard of. We've heard of measles. We may have had measles if we're old enough, also known as rubeola. The German measles variant of viral skin disease is called rubella. So rubeola for measles, rubella for German measles. There's another common skin virus in the Parvoviridae family, or generally parvovirus, causing a disease called erythema infectiosum, and associated with aplastic anemias as well. And then we have our smallpox virus caused by the vaccinia virus, part of the official Poxviridae family. And then we have what we call the VZ virus, because it causes both varicella, which is the common chickenpox, usually in children, as well as herpes zoster or shingles in adults, generally following a dermatome distribution. Same virus, different disease, different age groups. We have the family of the skin herpes viruses, generally HSV1 or herpes simplex virus 1 involved oral vesicular lesions, and HSV2 classically is involved in genital vesicular herpes lesions, but there's a tremendous amount of crossover. We can also talk about the hematopoietic system. Cytomegalovirus, also in the herpes family, causes a wide variety of infections throughout the body, lung, kidneys, but it has a hematopoietic affinity as well, so that's why it's classified here. But like the herpes virus in general, it's ubiquitous. It can infect just about anything. Epstein-Barr virus, a known virus involved in the Burkitt's lymphoma, is the cause of infectious mononucleosis. You may remember that before HIV here got its name, it was called HTLV3, and it wouldn't have been called HTLV3 if there wasn't an HTLV1 and 2. Well, the HTLV1, which, like AIDS, is a single-stranded RNA virus, causes a lot of the adult T-cell leukemias. And of course, the third portion of this, or the third named virus in this family, wound up being called HIV. So HIV, which is now generally HIV1 and 2, was originally HTLV3. And of course we are going to get and have gotten a big presentation on AIDS. Arboviruses are really nothing more than viruses which are generally brought to the human body by arthropods. That's why they're called arthropod-borne. They cause a wide variety of central nervous system and hemorrhagic fevers. If you hear of dengue, little outbreaks occur every now and then. Yellow fever, a very serious virus. These are all generally very serious diseases. Dengue has a relatively low mortality, but these are all potentially fatal viruses by virtue of the fact they cause hemorrhagic fevers. And you may have heard of the horrific Ebola disease. These are all arthropod-borne viruses. I think you might remember that the papilloma viruses, the human papilloma viruses, HPV, in the Parvoviridae family, double-stranded DNA, can't really be classified with the skin eruptions or skin lesions. they have a tremendous affinity for squamous mucosa, but not necessarily skin. So we can have a HPV infection in a non-keratinized stratified squamous mucosa, like the cervix or the vagina or the esophagus, or stratified squamous mucosas that are not part of skin. And then, I think rightfully so, moving up to the central nervous system, we have different types of viruses. There's a polio virus, now virtually non-existent, cause of major poliomyelitis epidemics in the 50s and perhaps early 60s. The JC virus, don't confuse that with JC disease, Jakob Creutzfeldt, because this is now a virus. This is not a prion, and it is a cause of a disease in the central nervous system involving a demyelinization called progressive multifocal leukoencephalopathy, chiefly in opportunistic infections in immunosuppressed patients. So if you hear of a JC virus, you know it's causing or indicted with PML. And then we have some more arthropod-borne viruses as being perhaps the major cause of viral encephalitises or encephalitides. So if you hear of Eastern, Western, Venezuelan, St. Louis encephalitis, these are all arthropod-borne viruses. And I think that's a good general classification of viruses, knowing that there is no precise classification as of yet. It wouldn't be fair if we didn't talk about another type of virus which do not affect humans directly, but they generally affect bacteria. And in the process of viruses like bacteriophages, plasmids, and transposons infecting bacteria, this bacteria may change its type of virulence with respect to humans. So you can't say that these viruses infect man directly, but they infect bacteria which infect man and may increase or even decrease its virulence or its susceptibility to antibiotics. So that's worth an honorable mention. Okay, let's move into the bacteria now. The bacteria, classified by various classical methods, whether they pick up the gram stain, whether they're gram-positive or negative. In the gram-positive bacteria, whether they're cocci or bacilli, they generally have a thicker wall with a 1-phospholipid layer, whereas the gram-negative ones have a thinner wall with a 2-phospholipid layer. And that's basically the basis between gram-positive and gram-negative gram staining, which would result in a smear which would be either blue for positive or red for negative. They can also be classified in their overall shape. If they're ball-shaped, they're called cocci. If they're rod-shaped, they're bacilli. Some bacteria do not take up the gram stain, and we'll get into those as well. Sometimes the bacteria can be classified, despite their shape and gram staining properties, into another category of whether they require oxygen to grow, the aerobic bacteria, or they do not require or need oxygen, the anaerobic. Sometimes there's a third intermediate category called the facultative anaerobes. But if you just remember the classification of bacteria as gram staining, shape, and oxygen requirements. Now we're going to get into another little busy diagram here, and I almost have to apologize for this because we'll be rattling off in the next chapter various infections, various types of bacteria, and I know it's going to be a little bit of busy work here, but we only have 4 left, and then we'll get into more graphic and hopefully more interesting stuff. I thank you very. Okay, I think we could summarize this last group of 3 bacterial infections as being the ones caused by organisms which don't have classical, predictable, or strong gram staining abilities. So that includes the treponemal infections, of which syphilis, caused by Treponema pallidum, is always at the top of the list and the one you may see. These other 2, yaws, caused by Treponema pertenue or pinta, caused by Treponema caritaeum. Probably you will never see these diseases. You will see the tuberculosis caused by the Koch bacillus. Koch was the guy who established the Koch postulates, which was the basis of how we know or how we can prove that a specific organism is causing a specific disease. The causative organism of tuberculosis is Mycobacterium tuberculosis, or less likely Mycobacterium bovis. There are a few other not as nearly as common mycobacterial diseases, or things you may not see too much, like leprosy, but you may see the atypical mycobacterial infections: Mycobacterial kansasii, Mycobacterial avium, Mycobacterial intracellulare. These are all atypical mycobacteria, like TB, but caused by organisms which are slightly different, and like TB as well, very likely in immunosuppressed patients. The actinomycotic type bacteria, sometimes you might say they're related to fungi as well. They don't stain well with the gram stain, so they're generally more likely to be seen on fungal stains, but nocardia and actinomycosis are both in that same category, and these are common in organisms, bacteria involving oral and upper respiratory tract. Okay, we're done with our 9 basic groups of bacterial infections. Let's say something about bacteria, and generally that's refreshing and pictorial. As you know, the common adjectives for bacteria are either bacilli, which look like little rods, or cocci, which are little circles. If they're gram positive, they're blue by common laboratory stainings or things you might do yourself. If they're gram negative, because of counter stains and so forth, they'll look red. So all 4 possibilities are common. Gram positive cocci, which are blue balls. Gram negative cocci, which are red balls, like you see here. Gram positive bacilli, which are blue boxcars or blue rods or blue bacilli. And gram negative bacilli. And we talked about why they are gram positive or gram negative. But from the point of view of just kind of remembering things logically, rather than trying to kill yourself with rote memorization, just remember one principle. Most cocci, commonly, clinically, are gram positive, and most bacilli are gram negative. Now, the reason why I'm showing this picture is because if you remember that principle, then it's easy to just remember the exceptions, because what I'm showing here are gram negative cocci and gram positive bacilli. So if you remember that the exceptions to the gram positive cocci are Neisseria, then you'll know if you see a coccus, a coxal, a ball bacteria that is gram negative, it's probably Neisseria. If you see a rod or a bacillus that is gram positive, like we see here, you might want to use the ABCCLLP acronym. And if you remember that, for example, the bacillus family, like the ones causing anthrax, like you see here, is gram positive. Cornybacterium is gram positive. Clostridium is gram positive. Lactobacillus is gram positive. Listeria is gram positive. And Propionibacterium is gram positive. So if you want to remember that like I do as BCCLLP as being the 5 common clinical bacteria, or 6, I'm sorry, that are the exception to the bacilli being gram negative rule, you could do it that way. And let's talk about now a general category of bacteria-like organisms. They're not exactly bacteria because they don't have cell walls. They don't make ATP like bacteria does. And you can't culture them. They have no life out of a cell. So for this reason, the clustering of the infections known as chlamydial infections, rickettsial infections, and mycoplasmal infections are also said as being infections due to obligate intracellular organisms. And they're called obligate intracellular organisms because they are obliged to live in human cells to survive. And remember, they have no cell walls like bacteria do. They have no mitochondria, and therefore they can't make ATP. And they have no life out of a cell, so they can't be cultured. So here are your obligate intracellular bacteria, and we'll may make some references to them, or we may learn about them in other chapters. Let's move into the fungi now. Fungi are very commonly classified clinically into a couple different ways. One of them is whether they infect skin or superficial structures, and one of them is whether they look like they are yeast forms or hyphae. So let's talk about dermatophytes. Most of the dermatophytes are caused by organisms or genuses of organisms like Trichophyton or Microsporum, which infect only the skin, so therefore they're superficial. And the family of these type infections are called Taenias. On the other hand, fungi, which characteristically infect deep tissues, like of which lung is of course the most common, would be genus names like histoplasmosis, blastomycosis, and coccidiomycosis. And another way to classify fungi, at least in the laboratory or under the microscope of a pathologist, is if they look like little yeasts or little balls, perhaps with little buds, or whether they look like they have branches or hyphae. So, for example, if you see something like this, and it's stained with the fungal stain, which of course the PAS stain or a methenamine silver stain are the two most commonly used ones. If you see things that look strictly like little balls, those are yeasts. Some of these little balls may have bumps on them. These are the yeasts that are giving rise to buds. If on the other hand you're looking at branches like this, these are hyphae. So hyphae are the branches, yeasts are the balls, and in this particular case we're looking at the world's most common fungus, which we all have, called Candida albicans. They are generally little buds and yeast, but they can also form these little branches, which they might want to call hyphae, or at least pseudo-hyphae. Okay, so I think we've pretty much finished the general overall discussion of viruses, bacteria, and fungi, at least from their overall classification and clinical type classifications. We're going to have to say a whole bunch of things about general parasites as well. And this is a good place to start. Parasites are either single cell infectious organisms called protozoans, or parasites could be organisms that have more than one cell called metazoans. And for all practical purposes, this means helminths or worms. And there's a couple of different kinds of worms. In addition, a third type of parasite could be arthropods, which would fall either into the insect or arachnid family. So think of parasites as protozoans, metazoans, or ectoparasites, which are arthropods. That's it for now. We'll continue with the general parasitology recap in the next group, and I thank you. Okay, we have moved up to the highest level of the evolutionary tree to this complex group of infectious agents called parasites, and we've said that there are basically three different general groups. The group that is composed of single-celled organisms, protozoans, a general, much wider group of multi-celled or metazoans, which are all generally in the category of worms or helminths, of which there are two different large groups, the roundworms and the flatworms. And we have these extremely complex critters now, known as arthropods, of two types of groups called the insects and the arachnids. by far the single most important clinical worldwide protozoan infecting and killing the largest number of people worldwide is malaria, or the Plasmodium species. There is another significant worldwide species of protozoum called Leishmania, transmitted by the bite of the sandfly, which has worldwide importance, but not so much in the United States like the rest of these. Amoebiasis, or amoebic dysentery, caused by an extremely common species of protozoan called entamoeba. The classical African sleeping sickness, transmitted by the bite of the tsetse fly, TSE, called trypanosomiasis. Toxoplasma, very commonly associated with cats, and cat feces in particular, as well as other things, being an important worldwide parasite. And last but not least, Giardia, which we have a picture of over here. Giardia is one of the few things which you look at under the microscope which appears like it's looking back at you. This is classical appearance. Giardiasis, obtained from bad water in a variety of conditions. Okay, this is my very last busy slide, which I'm very happy to report. But another way to think about parasites, the protozoans in particular, is their degree of invasiveness. The majority of parasites, which we talked about, probably are limited to luminal or epithelial surfaces, perhaps in the GI system. So they will, for the most part, cause a wide variety of gastrointestinal things. Some of them can be a little bit more serious, but as you would think, as they went up or became more invasive into the blood, into the cells, you would think they would generally become more serious diseases, and for the most part they do. But remember, the number one principle with parasitology, which applies, I think, to also many other aspects of life, including politics, is the successful parasite does not kill its host. So if you want to remember that many of these gastrointestinal parasites will stay limited to the mucosa, the blood parasites, protozoans, will, like Plasmodium, Babesia, trypanosomes, will actually invade the bloodstream, and red cells. And a wide variety of them will actually enter cells, the small ones, like trypanosomiasis, leishmaniasis, and toxoplasma. So you can also think of it as a progression of invasiveness. And thank God, I'm not too sure if you even got to see all the letters on here on YouTube, but we're done with our last busy slide. We're going to show some nice pictures now. The metazoans can be divided into two groups. If you want to equate metazoans in general with helminths, think of the roundworms, which are physically round, and the tapeworms, which are physically rather flat and segmented. So we have roundworms and tapeworms as our two classes of helminths infecting man. Also remember, in phylogeny, there's a third class of worms called annelids, which is what we see in our garden, the earthworms, but none of the annelids are known to infect humans. Helminths have complex life cycles, both an asexual and a sexual phase, and they involve almost always many more than one other organism besides man. The four most common roundworms are Ascaris, Toxocara, Strongyloides, and without a doubt, the most common one, and the one you may likely even see if you practice in the U.S., Enterobius, or the pinworm of the appendix. The flatworms, the most common one in the United States is Hymenalepsis, but worldwide, the beef tapeworm, or Taenia saginata, and the pork tapeworm, Taenia solium, have worldwide importance too. And of course there's a fish tapeworm called Diphyllobothrium, and the specific genus and species is Diphyllobothrium latum. Let's take a look at a pinworm. Not that uncommon in the United States, usually in kids, often in epidemics. The best way to diagnose pinworms is to actually take a close look at the anus and to see if you see little worms crawling out, often in kids who have been scratching a lot. And of course the females are about 5 times as big as the males. The female is about 1 centimeter, male's only a couple millimeters. So very often they're seen in this in appendices as incidental findings. So if this is a appendix which looks pretty normal, or at least uninflamed, both grossly and microscopically, you may often see little tapeworms in them. And basically the worms stay in the gastrointestinal system. They generally don't invade into tissues for the most part, and they're often relatively asymptomatic as well. Now it's not my purpose to go into all the complex life cycles of all the parasites, but I think in the case of this roundworm called Ascaris lumbricoides, I just want to give you an example of a life cycle of a parasite. I guess a good place to start is because you know that the Ascaris lumbricoides inhabits the small intestine, and once again females are a lot bigger than the males. Let's just kind of spend a minute or two to go through this life cycle. First of all, the adult worms, which you see here, they live in the lumen of the small intestine. A female could produce maybe a couple 100,000 eggs per day, and they're passed through the feces. Now, if the eggs are unfertilized and they're ingested, of course they're not infectious. But if they are embryonated or they're fertilized, they can be infective as much as 18 days to several weeks after they're passed. Now these fertilized eggs can once again develop another stage now in which you have an ovum being produced, which can be ingested by a human again. Now these eggs can also develop in the lungs and wind up ascending in the respiratory tract to the larynx as well, which they're swallowed again and back into the intestine. These are very, very, very probably the single most important roundworm of worldwide importance. So this is Ascaris lumbricoides. It's not meant to be memorized. It's just meant to show an example of how parasites have these complex both sexual and asexual stages involving humans as well as extra-human and sometimes other animals as reservoirs as well. Well, our little beeper went off, so we're going to continue this parasitology quick overview into the next 10 minutes. Thank you very much. Okay, we have run down the entire evolutionary tree of critters that could possibly result in human infections, all the way from things which barely have DNA all the way up to multicellular organisms that may look a lot like we do. And what I want to do now, hopefully a little bit more logical and not throwing so many big words at you, is talk about general concepts of the way we can defend ourselves, or the barriers that we have from infectious pathogens in general. And I hope this is very, very logical, but when you think that you have a body which should remain pathogen-free, the basic defense between this body and all the critters we just talked about are, first of all anatomic mucosal possibilities. Skin, GI tract mucosa, respiratory mucosa from airborne inhalation, from oral ingestion, and even urogenital. All of these are designed to protect us. They have a certain arrangement of cells. They are underlined by lymphoid tissue. They may secrete substances which have antibodies. And this basically is the steady state system that we have to protect ourselves from pathogens. It's the breakdown of these barriers that results in infections in general, no matter what type of organism from the phylogenetic tree that we're talking about. When you think about an infection going on in a region of the body, you can talk about spread of an infection as well. This is also another general term. And if you think about it, or if you want to think about it, the spread of an infection is pretty much follows the same routes and same channels as the spread of a tumor. First of all, you can have a direct extension of the inflammatory process into all the surrounding regions. So if you know where the infection is and you know what the neighbors are, you might suspect that some of these neighbors can become involved with direct extension. Lymphatics pick up inflammation and bacteria and antigens and lymphocytes and neutrophils and debris and process them through lymph nodes just as though it was a tumor process. Pathogens and inflammatory processes can get into the bloodstream and infect every place that the blood goes to, which of course is everywhere. And it can also follow nerve tracts or nerve sheaths as well. This is exactly the same type of pattern we see with malignant tumors, isn't it? When we talk about release or transmission of pathogens now as a concept, no matter what type of organism we're talking about, one of the ways to release a pathogen is anatomically possible skin shedding, coughing or sneezing, through the urine, through the feces, through the blood, or by virtue of vectors or another type of organism, usually an insect, which acts as an intermediary in the dissemination of the pathogen. Another general release, which is not quite anatomically as logical as the rest of these, are what we call STDs, sexually transmitted diseases, and those are usually either mucosal, blood, fluid kind of oriented. So, but it's still considered to be a type of transmission. They'll talk about the sexually transmitted diseases. Another main principle which will never die is something that's big enough and important enough to summarize in these three little letters. It might look like Ohm's law to you if you're an electrical engineer, but no matter what kind of infectious process we talk about in a human, the thing you always have to keep in mind is that the overall infectivity of a pathogen is directly proportional to this concept of what we call virulence, or the capability of an organism to cause an infection. So I is directly proportional to V. However, it's inversely proportional to this thing that we call resistance, which is your immune system. So this is why many horribly, potentially horrible virulent organisms might not produce much of an overall infectious response, simply because there's a lot of body resistance or strong immune system. On the other hand, when this R gets smaller, or your resistance or immunity goes down, even the most wimpy of pathogens can cause major infections, including many organisms which normally don't even infect us. So let's talk about one last concept of infectivity again. No matter what type of a bug we're talking about before we get into the specific infectivities. A pathogen can have a direct effect, or an agent, if you will, on a host cell. That's the most clear, straightforward type of infectivity, because ultimately it's cells which are damaged or it's involved in infectious processes. The agent or the pathogen can produce toxins. This is very, very often seen with bacteria, whether they're endotoxins or exotoxins, which cause the necrosis or the effect on the cell. On the other hand, the agent may evoke a host cellular immune response, which is significant enough to cause damage and death and necrosis as well. So what does this mean? Maybe I should have made this a little more logical. A bug can get to your cell directly. It can make toxins which get to your cells, or in the process of your body reacting against this bug, you can have cell damage on the basis of that reaction. Okay, now that we have gone into infectivity in general, let's say a couple of specific words about some of the organisms. We'll start with viruses and then go up to bacteria. Well, the common thing about all viruses, besides the other things we mentioned, whether it's single or double-stranded DNA or RNA, is that they have to attach to a cell. So they have to have a way to get in. Once they get in, they have to transcribe. They have to undergo transcription in order to replicate and make the things that they normally do. So all viruses have to attach. They have to enter the cell. They have to undergo transcription. And then, with the handful of genes that they have in them, they have to use the host's materials for translation. This may result in seeing perhaps some viral inclusions inside of a cell. Or perhaps we can see, if the cell is damaged enough, which it often is, reduced host cell function, or perhaps cell injury, or lysis, or death. On the other hand, that virus can live in a cell perhaps for many, many years without causing much disease or change of any type, and just stay there. These so-called large latency periods of viruses in cells are often talked about when we talk about latent viruses perhaps causing a neoplasm. So really, what are the few things viruses can do? Well, they can stay in your cell, they could damage your cell, or they could just stay there for a long time and ultimately result in mutations which are going to result in neoplasms. We mentioned a whole wide variety of them in the chapter on neoplasm, and we may make a few references now as well. So that's the general possibilities for viral infectivity. We'll start the next group with bacterial infectivity, and I thank you very much. What are the general elements of bacterial infectivity? Well, like viruses, they have to get into your body, and whereas they may not enter your cell, they still have to get into your body. So they have to break down the barriers. And because bacteria do not usually have a direct entry into a cell, although they may, they have to do some damage in other respects. And the most common way bacteria do damage to cells is by virtue of toxins. Now, if that toxin is actually part or breakdown of the bacteria itself, it's called an endotoxin. This is almost exclusively the result of gram-negative bacteria. I think there's some argument that in some of the gram-positives, like staph, that may be present. Exotoxins technically are toxins which does not result from bacterial components, but are simply secretions of bacteria. And you can see exotoxins of various types with both gram-positive as well as gram-negative bacteria. Let's talk about the concept of immune evasion. Here we have now bacteria, viruses, or any of the other critters we talked about in contact with the host, the human. And the humans have an immune system, both natural as well as acquired, to fight, prevent, destroy, whatever it takes to neutralize itself from this pathogen. Well, Immune evasion is the science by which the bacteria or viruses or other critters have developed to evade being attacked by the host. And here's various different mechanisms. The most obvious mechanism is just to make itself inaccessible anatomically to host defense. If you remember the Karate Kid, Mr. Miyagi says, best way avoid punch, no be there. Well, in general, pathogens have ways of simply avoiding immune mechanisms, both anatomically and physiologically. One thing they could do is to vary their antigens or mutate, so the antigens which would normally be the target of host attacks are no longer being recognized. So mutation is a very, very common type of immune evasion. One thing to do is to shed their antigens. You know, like if you remember the movies where the airplanes or the torpedoes would jettison things to make it look like that they were still there, and while the body was attacking the jettison stuff, the submarine or plane would actually be getting off scot-free. So shedding the antigens is another mechanism for immune evasion. These are all parts of virulence, both directly and indirectly. Another thing is to resist the innate immunity. In the previous things we've been talking about so far, these are all mechanisms involving antigen antibodies or learned immunity. Sometimes it could just resist innate immunity, which are the things which are not involved with antigen antibodies, perhaps things simply like a barrier resistance. Another thing to do is to fight back. And one way that these critters not only can avoid being beaten up is for them to fight back. So there are a variety of mechanisms for pathogens to impair the same types of T cells which would normally attack them as well. So I think you should generally know that these are 5 mechanisms of immune evasion. It would not be fair if we didn't talk about in general this whole concept of I equals V over R. Let's talk about immunosuppressed hosts, or hosts that don't have much defense. In practical clinical important, we're talking about immunosuppressed patients. We're talking about AIDS patients. We're talking about patients with other immune diseases. We're talking about patients with taking immunosuppressives, chemotherapy. What are the commonly seen infections of immunosuppressed hosts? Well, things which normally might not affect normal people can cause a significant infection in immunosuppressed people. A little protozoan or fungal, almost fungal-like organism called Pneumocystis carinii. Now it's better classified as Pneumocystis jirovecii, spelled with a J. The taxonomists have changed the rules on us every few years, but generally PCP is one of the most common organisms to affect immunosuppressed hosts, which normally wouldn't affect normal people as well. And that's also true with Cryptosporidium, a tiny protozoan which is involved in a variety of diarrheal and gastroenteritis diseases in immunosuppressed people, which normally would not involve healthy people at all. Toxoplasmosis, another very, very common parasite affecting AIDS patients. Very, very, very not likely to infect people with normal immune systems. Fungi are also notorious for infecting immunosuppressed hosts. And besides Candida, which of course is very common in any immunosuppressed person, diabetics, the probably most biggest category, the usual 3 deep systemic fungi, histo, blasto, coccidio, very commonly seen in immunosuppressed patients as deep systemic infections. Bacteria, anything is possible, of course, but TB, once we thought we had that epidemic on the run. Turns out that it's still very, very common in immunosuppressed or AIDS patients now, as well as these critters like nocardia, which are halfway between halfway between fungi and bacteria, and salmonella, a common enteric pathogen, much more likely to cause damage in an immunosuppressed person. The herpes virus family of viruses, CMV, herpes simplex, varicella zoster, very likely to cause damage in immunosuppressed patients relative to what they would normally do in healthy patients. Diagnostic techniques, well, one way to diagnose critters is to actually look at them. So in all the images we've been looking at, especially in some of the parasites, just a direct pathogen imaging is obviously what you want to do. With bacteria, we have gram staining. There's a variety of other stains to stain bacteria which are not responsive to gram stains. For example, the acid-fast bacteria. Bacteria in particular can be cultured and relied upon to produce various patterns of growth in those cultures for identification. If an organism cannot be cultured, you may put that organism, especially viruses, onto human cells or other types of cells, and to look at what the effect would be on those cells, or a CPE, or cytopathological effect. And sometimes the specific type of CPE would determine what type of organism is present. Of course, if you can't grow or see or measure or look at the organisms directly, you could actually look at their antigens by virtue of seeing what antibodies the patient is making. So that's one indirect way. The most spectacular, specific way of identifying organisms with the greatest amount of sensitivity and specificity is PCR. And that's basically taking the organism, breaking it up into its DNA into oligonucleotides, and then looking to see if those specific oligonucleotides match up with known oligonucleotides. And this is generally the process which we look at in AIDS for viral load. So these are all common diagnostic lab techniques for identifying specific organisms. And will we have time for one more slide? Oh, sure. I think we'll put this as the beginning of our next thing, because now we're going to talk about patterns of host responses. We're going to talk about what reactions to these pathogens look like. What does infection look like? We've dealt a lot about this already, but we're going to also look at some more cellular host responses in the next group. I think we can start out this 10-minute segment by reminding you that infectious diseases are probably the single biggest cause of general inflammatory diseases. Probably the second biggest cause would be autoimmune diseases. So a good principle is that if the antigens causing infection are coming from the outside of your body, that's infectious disease. If the antigens causing infection are from your intrinsic antigens, that's autoimmune disease. So all of the patterns that we talked about of inflammation in the second chapter are basically still present here, aren't they? So we talked about acute infection, chronic infection, subacute granulomatous, abscesses, fibrosis, blah, blah, blah. They apply here. And I would also like to remind you that it's not very likely that a specific type of organism will produce a very specific type of inflammatory reaction. What I mean is, it'll generally fall into clusters. You may see abscesses in any type of infection. You may see granulomas in many other types of infections. But it's not very likely you could identify a specific organism just from looking at a specific pattern, anatomic pattern of inflammation. This is a good example. We'll call this acute appendicitis. And as you know, acute appendicitis is not really caused by a specific bacteria. It's generally caused by obstruction to blood flow and maybe secondary overgrowth of bacteria. But this could be any type of organism. Because it's basically neutrophils, you might want to call it suppurative or purulent. And as you know, both gram-positive, gram-negative, cocci, bacilli, even viruses can produce this type of pattern of inflammation. But let's take a look at another thing which we saw before called an abscess. Okay, localized collection of neutrophils, a bag of pus, virtually 100% neutrophils, maybe some fibrin, localized in one place. Could this be a bacteria? Could it be a virus? Could it be gram-negative, gram-positive? Could it be a parasite? Could it be a protozoan? Yes, it could be. But I want to point out that patterns of inflammation are not specific, at least not really 100% specific. In some cases, like granulomas, you might be able to narrow it down in terms of what type of organism is infecting. Here is something which you might say, and you say, gee, this kind of looks like it's either organizing inflammation or maybe chronic inflammation, because there's a lot of lymphocytes and macrophages here, but I see a lot of blood vessels, a lot of edema. Could this be a suppurative or acute inflammation from anything which is now organizing? It certainly could be. Because you might be starting to see the entrance of perhaps some fibroblasts. Could it be the beginning of fibrosis? Yes, it could be. Here's another classical type of inflammatory reaction to a pathogen, and it's our old friend, the granuloma. Now, the neat thing about granulomas is that when you see this as a pattern of infection, you still know theoretically it could be due to anything. However, there are certain types of pathogens that classically cause granulomas, and it's not 100% specific, but when you see a granuloma, you are generally most likely dealing with either a mycobacteria, a fungus. There's a whole bunch of scattered, bacteria and viruses that cause granulomas as well. Or the cause of it might be a foreign body or sarcoidosis. So just kind of keep in the back of your mind that when you see granuloma, run down your mind real quickly. TB, other acid-fast bacilli, a variety of fungi, sarcoid or foreign bodies as the four common causes. And specifically with fungi, a fungus, whether it is a yeast fungus or a hyphal fungus or a superficial fungus or a deep fungus, is much more likely to produce a granulomatous pattern of reaction than any other type of infectious organism. And there's a reason for that, and I'll probably get around to telling you someday. No, I think I'll tell you now. The reason why fungi cause granulomas is when you look at the pure size of the organism. Generally, fungi, especially hyphae, are large. They're many, many times larger than viruses and bacteria. So as a result, not one single cell can easily deal with that. So macrophages join up in groups to form these macrophage syncytia, some of which contain multiple nuclei in one cytoplasmic mass called the giant cell. And this is the body's mechanism for attacking pathogens, which are very large. And this is why fungi classically produce a granulomatous pattern of inflammation. Does this look familiar? It might. You could see it's some type of glandular organism. Perhaps it's a pancreas. Perhaps it's a salivary gland. I don't know what it is. But you could see that there are little bands of collagen entering in here, although you could still see the persistence of some probably mononucleated inflammatory cells. So this is early fibrosis. And as you know, fibrosis is generally the end stage of chronic inflammation. and it's still a non-specific pattern. And just as non-specific as fibrosis following chronic inflammation, you can have the deposition of blood pigment or hemosiderin picking up by macrophages to cause little brown granular pigments inside of macrophages, or if you stain them with the Prussian blue dye, looking very, very, very blue. Just know that hemosiderin deposition is also commonly part of a chronic inflammatory and even infectious process. Last but not least, very, very common in chronic fibrotic long stage inflammatory processes is calcification. And calcium often looks like a little shattered crystal, very, very dark blue. And if it's large enough, of course, it usually is not in macrophages at all, is it? Okay, now that we have seen the general histologic patterns of body reaction to the infectious organisms, let's talk about in more detail the 4 biggies. You know, we went through a lot of interesting things and prions and little viruses that infect bacteria, but in human diseases, the kind you'll be seeing, what are really the 4 biggies? Well, the 4 biggies of infectious disease are viruses, bacteria, fungi, and parasites. And we're going to spend a little bit more detailed time now zeroing in on some of the common patterns and some of the common diseases in each one of these categories. We won't go into everything because we don't have the time. It's not worth it. And we'll probably be dealing with these more when we get into the systemic diseases. But I think we wouldn't be doing you justice if we didn't start talking about some of the general patterns or classifications of these 4 different types of pathogens. We can start out with viruses. There are 4 patterns of viral diseases. There's a transient acute clinical pattern, things that appear rapidly, perhaps go away rapidly, perhaps never come back, like measles, mumps, polio, West Nile virus infections. There are the chronic latent viruses. Many of them are in the herpes family, and some of these, like we said before, may give rise to neoplasms. So the general herpes family of viruses is famous for causing chronic latent diseases which may reoccur many years later and come back and maybe go away or maybe not go away. There are the chronic viruses, which are generally associated with hepatitis, and we have hepatitis going all the way up to E now, A, B, C, D, E. For practical purposes, hepatitis A, B, C are the ones we'll be zeroing in on. And as you know, even though this is a chronic pattern, some of the chronic viruses, especially B and C, can also be indicted in liver tumors or transforming. And that's our 4th category of viral infections, are the transforming viruses. So if you take the Epstein-Barr virus or EBV, that is very much indicted. In fact, the cause of a type of malignancy called Burkitt's lymphoma. It can also infect tissue, including hematopoietic tissue, to cause acute patterns of diseases too, like mononucleosis. We know the human papillomavirus, or HPV, is a transforming virus, and we'll be going into these 4 categories. The types of bacterial diseases that we'll focus in a little bit more on, and the way they're generally classified, although it's not totally logical because there is some overlap, would be the gram-positives, usually cocci, gram-negatives, usually bacilli, but as you know, there's a handful of gram-positive rods. Mycobacteria, not only the tubercle bacillus or acid-fast bacillus, which causes TB, but a few other bacteria like the atypical mycobacteria and leprosy, spirochetes, anaerobic bacteria, and obligate intracellular bacteria. So These last four, generally, with the exception of the aerobic, don't have easily gram staining patterns. The mycobacteria are stained by the acid-fast stain. The spirochetes don't really take up any good stain, but they have a characteristic appearance. The anaerobes are usually gram negative. They're usually bacilli, and the most common of which is a gram positive bacilli in the Clostridium family. And of course we have this group of what we call quotes bacteria, but they don't behave totally like bacteria in that they can't be grown easily outside the human body, so they have to be grown inside of cells. We're also going to get into the fungal diseases, both the yeasts and the molds, as well as the common yeast candida and cryptococcal yeast infections, the most important of which is a meningitis. And then we'll be talking a little bit about the hyphal, or the molds, and saying a couple words about aspergillus and mucormycosis, both of which are infinitely more common in immunosuppressed patients. We'll get back into parasites again a little bit, zero in on a couple of life cycles, go into the protozoans and a couple of the worms. Okay, as promised, we're going to talk about 4 categories of viral diseases. And we said the first one was the transient acute viral diseases, the one that occur acutely, not only pathologically, producing acute patterns of inflammation, but clinically acute, appearing suddenly. And of course the childhood viral diseases like measles, mumps, polio, most of which are gone by now, as well as some which aren't, like West Nile, are all viruses which appear suddenly, can disappear suddenly, have a certain good amount of immunity attached to them in the convalescent phase, but some of which can be very severe. So let's look at measles, although you may never hopefully see a measles case. Measles is an infection, as you know, in children of skin, but it can also involve lung, brain, other tissues. And from a pathology point of view, besides having the classic spot appearance, often causes fusion of some of the epithelial cells, so they appear to be like giant cells. So they talk about a measles giant cell. And unlike the giant cells we see elsewhere, these are not histiocytes. These are not macrophages. These are actually partially fused epithelial cells. Another thing to remember in measles is that it is a respiratory infection. There's usually severe upper respiratory infection, and often before the appearance of the skin lesions, you could see, perhaps besides a pharyngitis, little whitish patches called Koplik spots, K-O-P-L-I-K spots, named after Dr. Koplik. Here's another disease I hope you never see: mumps, infectious parotitis, involving primarily the salivary gland, the parotid gland, and usually one side more than the other. Often a benign disease, but also can infect pancreas, testicles, and whereas you can see a nice little swelling of this young man's left parotid gland and this young lady's left parotid gland, it's usually not really symmetrical. It'll affect one side more than the others. This is an actual histologic view, not of a salivary gland, but of a seminiferous tubule, in which you see infiltrates of neutrophils in that tubule. Pancreas can also be involved. Lung can also be involved. Central nervous system can rarely be involved. Here's another disease I hope you never see. It's poliomyelitis, caused by the polio virus. Here is an anterior horn motor cell, and you could see that it is starting to have an infiltrate of inflammatory cells. Here's a much wider and a lower power view of the process in which you see edema, demyelinization, more infiltrates of inflammatory cells. This is a classical appearance for polio. And whereas in some of the other acute viral infections we saw there could be regeneration, once these anterior motor horn cells are destroyed, there's no regeneration. So polio infection can result in very severe, lifelong, crippling disease. Here is an acute type of viral encephalitis. This one is West Nile. And like most of the other viral encephalitis or encephalitides, the primary histologic pattern is a little cuffing of lymphocytes around blood vessels in the central nervous system, the so-called Virchow-Robbins space. So technically there's a theoretical space surrounding blood vessels, and in the early stages of viral encephalitis, whether it's West Nile or another type, you can see the infiltrates of inflammatory cells going around those blood vessels. Let's talk about the chronic latent viral infections as the second category, of which the herpes family is the main classification. You have herpes simplex virus, CMV, also in the viral family. I think I'll make that little M red if I possibly can. And we have the varicella zoster virus, also in the herpes virus family, causing a chronic latent pattern of infection, which means clinically it may resolve, but it may come back and go away and come back years later, come back when the immunity is down, come back when the patient is immunosuppressed. These are viruses that just don't really go away too easily, but they can relax and not do much acute tissue damage for long periods. Here is a vesicle of herpes simplex in the arm. Here it is genital, and it's basically the same virus. There's a lot of crossing over, although technically the oral herpes simplex is HSV1 and the genital is classically HSV2. Here is a histologic view of the nucleus of some of the squamous cells. They can have these bright inclusions. These are not virus particles themselves. There may be viruses in them, but the virus itself is generally much smaller. Here is a CMV, also in the herpes family. In this case, also like herpes, often in immunosuppressed people. In this case, it's in the lung. It could be in the skin. It could be in the kidneys. And the classical feature of CMV is that, like herpes, you get these intranuclear inclusions, and here's a really good example of one. And normally you don't have to look too hard to find them. But once you do, if you see a real specific basophilic intranuclear inclusion in an area of inflammation, most likely that is CMV. Because as far as I know, if you do a good stain, CMV is the only viral disease I could think of offhand that causes very distinct basophilic intranuclear inclusions. Here's a third type of chronic viral disease by the VZ virus. It's called VZ because it causes both varicella as well as herpes zoster. So the same virus that causes chickenpox causes shingles. Here's a classical dermatome appearance in an adult. Here's an inflammatory reaction in the area. Here's an actual vesicle. So like some of the herpes simplex, it's basically a vesicular pattern of skin reaction in which there's a lot of secondary inflammation. And let's move into our third category of viral type infections, are the so-called chronic viral infections, of which hepatitis is the most common. Now, you know, I think we'll have to stop here for a minute and continue with this in the next group. Okay, we have covered the acute transient, and chronic latent viruses. Let's talk about the regular old chronic viruses. And the best example of that is in our discussion of chronic hepatitis. So the word chronic viral infections is almost synonymous with the various hepatitises, or hepatidities, if you will. We're up to about 6 of them now. A, B, C, D, E. A, B, and C are the most common ones and the ones of most concern for you. And they're all chronic infections. They all have acute phases. And we'll be talking about them more in the GI chapter, but if you just kind of remember, A is the mildest, the most common. I think it approaches 100% prevalence in underdeveloped nations. B, the so-called serum hepatitis, is probably the single most serious common type of hepatitis in the acute phase, the most serious. And of course, hepatitis C, probably the most common cause of persistent transaminitis, or elevation of AST and ALT in adults in the United States. Let's talk about chronic viruses' behavior in general and use hepatitis as the example. Here is a normal liver. I hope you remember this from the histology series. And as you kind of remember, the blood flows from the portal vein to the central vein through these sinusoids. And that is the overall direction of flow in the liver. So the concept is, if you have a toxic substance coming from the central vein here, which is surrounded by the portal triad, towards the central vein, which of course is surrounded by nothing, the first part of the liver lobule to be involved with pathogens or toxins is number 1, what they call the periportal zone. And then as you go towards number 2 and number 3, the exposure gets less and less. So the point I want to make is that toxins and pathogens are more likely to cause changes in the periportal part of the liver lobule. Now let's say that the primary process is ischemia, or lack of oxygen. Well, because this is the first part of the liver to get the blood flow, this would get more relative oxygen than the central lobular area. So the general principle for all hepatic diseases is summarized by the fact that toxic substances produce changes in the periportal area, and ischemic changes produce changes like necrosis in the central lobular area. So it's no surprise that chronic hepatitis basically starts out in an acute phase, but as seen in the chronic phase, would have a infiltration of lymphocytes, chronic inflammatory cells, macrophages, in the portal triad area, and the amount of damage or a spread from this infiltrate determines the amount or severity of the disease. Here's an acute picture of hepatitis in which we see Councilman bodies, which used to be thought of as being the diagnostic features of acute hepatitis B. Actually, all they are individual hepatocytes that are undergoing apoptosis. Okay, let's talk about our fourth and last general clinical group of viral infections. We talked about the acute transient. We talked about the latent, chronic latent. We talked about the general chronic. And let's give an example now of the two most common transforming groups of viral infections. And of course in humans, that would be the EB virus, or Epstein-Barr virus, and the HPV, human papillomaviruses. And both of these are viruses which can cause infections, acute infections of various types, but they are also indicted in the development of many, many human malignancies. Let's start out with EBV. This is a virus that causes a type of lymphoma known as Burkitt's lymphoma. But guess what? It also causes infectious mononucleosis, the same virus. In mononucleosis, we have a pharyngitis, lymphadenopathy, splenic enlargement, liver damage, and of course the diagnostic, most common diagnostic serologic test is the presence of heterophile antibodies You have to have a very severe pharyngitis to have mono. And of course, the reason why it's called mono is because the lymphocytes are also involved and infected, and they take on atypical features. In other words, this classical looking lymphocyte here looks a little bit more like a monocyte now because the nucleus has gotten larger and a little more irregular, and that's probably why it's called mono. And a lot of people mistakenly think that monocytes are elevated in mononucleosis. That's wrong. It's actually lymphocytes that look atypical and are called monocytes that are the cells seen in the peripheral sphere of infectious mononucleosis. And if you can agree that this virus imparts some atypia to the nucleus, perhaps in the same type of way it makes the lymphocytes of Burkitt's lymphomas malignant, then you can understand what's going on here. By the same token, let's look at a malignant cell of a squamous cell carcinoma. I don't think I have any problem convincing you that these are malignant squamous cells. They're big, dark, hyperchromatic, pleomorphic. They're as malignant as hell. And they're malignant because they have been transformed by forces which has been spearheaded by HPV. And as you probably know, if you have taken the vaccine or encourage your children to take the vaccine, it's basically types 16 and 18, but there's a whole bunch of types of HPV, and they're responsible for a whole multitude of squamous malignancies and squamous benign proliferations of any squamous mucosa, whether it's cervix, whether it's vaginal, whether it's oral, whether it's skin. HPV loves to cause skin tumors. Okay, we're done with viruses. Let's get into the bacteria. And we've already seen the slide. We talked about the general classification of bacterial infections being gram-positive, primarily cocci, being gram-negative, primarily bacilli, but there's exceptions for each group. Then the groups that don't stain, like the mycobacteria, having to use a special Zeal-Nielsen or acid-fast stain rather than the gram stain. The spirochetes, which do not stain at all and have a hard time growing out, being cultured. The anaerobes, which can stain either gram-positive or gram-negative, usually, most commonly, gram-positive rods. And then this family of obligate intracellular bacteria, which can't be cultured and are not really bacteria, at least not classically. So here we go, gram-positive cocci, staph and strep, probably almost synonymous with the term gram-positive cocci, can cause infections anywhere, literally anywhere, skin and upper lower respiratory tract most commonly. Staph, of course, has been indicted and as the cause of toxic shock syndrome, releasing super antigens. It's a common cause of both lower or lung respiratory infections as well as uppers, the most common cause in wound and skin infections, causing a type of disease with strep called impetigo, a very common cause of inflammation of the hair follicles, perhaps secondary to acne or other localized follicular eruptions, being the most common cause of endocarditis in drug users, and of course its toxins representing a very common type of food poisoning as well. I think that's what we'll call it a stopping for now, and then we'll start our next group with in many ways, the other extremely common gram-positive coccus, streptococcus, behaves very remarkably like staphylococcus. There's a few differences, and let's kind of just summarize them. With the strep family of bacteria, there is a division into A, B, C, D, E for various types and species and so forth. But probably a more important and independent type of division is what kind of hemolysis they would cause. So often you'll hear the strep classified as alpha hemolysis for alpha strep, beta hemolysis for beta strep, and there's even a non-hemolytic type. The beta hemolytic strep right here are the most important ones and the most dangerous ones because they cause a more complete pattern of hemolysis. Like staph, the strep can infect just about anything. Basically, skin, wounds, upper, lower respiratory infection. As you remember, the strep group of bacteria are the most common cause of the classical lobar type of pneumonia, which we'll get into when we talk about the pulmonary system. The strep also have a remarkable propensity for causing endocarditis, infecting heart valves. And like the staph, they can cause a fasciitis, soft tissue, skin, and so forth. But different from staph cocci, strep gram-positive cocci have a few diseases which they may not cause directly, but they're linked to. So when people have scarlet fever, is that perhaps caused by a strep directly? Well, possibly, but it's really more the effects of the scarlet fever is a condition that follows a strep infection. By the same token, a child or children or anybody that has rheumatic fever has a history of a previous strep infection as well. And of course, the most classical acute childhood type of glomerulonephritis, formerly called post-streptococcal glomerulonephritis, is now generally just called acute glomerulonephritis. The point I'm trying to make is that the big difference, one of the big differences between strep and staph, is that strep is associated with sequelae of diseases which may not be caused by the bacterium directly, but is known to follow the disease, strep infection, like scarlet fever, rheumatic fever, and glomerulonephritis. Another disease that's almost unique to strep is a disease here which we see a picture of called erysipelas. I hope I'm pronouncing it right. It's a disease of immunocompromised hosts, often the very young and the very old, and it causes diffuse reddening of skin, and this is a classical case of it. Okay, let's talk about some rods now, or the bacilli. And it's probably easy to run down and classify the gram-positive bacilli or the gram-positive rods to begin with, because there's only a relatively few of them. Almost all of the other rods or bacilli are gram-negative. So often the term gram-negative rod is almost redundant. But there are a few diseases like diphtheria, listeria, anthrax, nocardia, clostridium, which are caused by gram-positive rods. And it's not my desire to go into the details of all these diseases. We may do that when we get into the organ systems, or we may not, but I think it's worth saying a couple words about each one. Diphtheria is a serious disease that is really no longer seen because of immunization, at least in this country. It's a severe upper respiratory tract illness. It's characterized by a sore throat, low fever, and there is an inherent fibrinous membrane which adheres to the pharynx and the tonsils or nasal cavity. Is called a pseudomembrane. So when you hear the term pseudomembrane referring to a thick fibrinous exudate associated with a severe upper respiratory infection, they're usually talking about diphtheria. Listeria is a type of is several things. One of the things it's a foodborne infection that has a very, very high fatality rate, perhaps around 25%. It's also a cause of meningitis in newborns by virtue of the fact that it has a remarkable propensity to infect the placenta. And many of the newborn infections that are gotten through the placenta are from listeria. Anthrax, we have heard so much about this in terms of bioterrorism. Classically, Bacillus anthracis is an infection of which can be gotten from either oral inhalation or cutaneous routes, and It is a feared agent of bioterrorism. Nocardia, or nocardiosis, is a gram-positive rod. Some people think it's kind of related to fungi as well as in its properties. That classically causes respiratory infections in immunocompromised hosts. So if you hear somebody has nocardiosis, chances are they're immunosuppressed through one method or another. It would not be fair if we didn't say a couple words about Clostridium. Clostridium is the last gram-positive bacillus or gram-positive rod in this group, and it's a very important cause of food poisoning. It has several different species. Clostridium botulinum releases a toxin which causes a severe type of food poisoning. Clostridium perfringens is the most common cause of gas gangrene. It's an aerobic bacteria that generates gas. And of course, Clostridium tetani is the causative agent of tetanus. So I feel like we have probably adequately run down gram-positive rods. Let's talk about the gram-negative cocci now. And there's only really one genus, it's Neisseria. And Neisseria gonorrhea is the cause of gonorrhea. Neisseria meningitis is one of the leading causes of a epidemic type of meningitis, a feared type. And it is not the usual childhood type, which is Haemophilus. This is in older people, children, older children, young adults, old adults. So I don't know, my taxonomy may not be perfect, but to tell you the truth, I really can't think of any clinically important gram-negative coccus except for Neisseria. And of course, if you did a gram stain on these, your algorithm would be, once again, to look at the organisms. Are they round, cockle, or are they long like hot dogs or bacilli? If they're red, they're gram-negative because of the counter stain, and if they're blue, they're gram-positive. So red balls are gram-negative cocci. So let's get into our last group here, called gram-negative rods. Most bacilli are gram-negative, and they cause a wide variety of infections. Some of them live normally in the colon. They cause a wide variety of pulmonary, renal, soft tissue infections. And whenever you hear a discussion about the gram-negative rods, E. coli is always at the top of the list, whether it's a colon infection or a urinary tract infection, perhaps a neonatal infection. So you always have to remember, when you run down the gram-negative rods, E. coli is at the top of the list. Technically, all these other bacteria stain gram-negative as well, and we'll finish running them down in the next 10-minute clip. And I thank you very much for now. Often the term gram-negative rod or gram-negative bacilli is used as gram-negative infections too. And when they are, they almost always refer to bacilli and not that single one gram-positive cocci called Neisseria. So for the most part, because it's such a wide spectrum of diseases, let's just say that the gram-negative rods cause a wide variety of gastrointestinal, pulmonary, and urinary tract infections. And the list that you usually see, is almost always headed by E. coli, which is the most ubiquitous, the most universally disease-causing bacteria, it seems. In addition, Bordetella pertussis is a gram-negative rod, and it is the cause of whooping cough in children. Another specific bacteria, Yersinia pestis, formerly called Pasteurella pestis, is the causative agent of plague. A relatively rare, at least in this country, type of venereal disease called chancroid, because it looks like a chancre, but it's not syphilis, is Haemophilus ducreyi. So the Haemophilus are also gram-negative. But when you look at the other gram-negative rods and you hear a list of causative organisms for a wide variety of, let's say, pulmonary or urinary tract infections especially. E. coli is at the top of the list. Klebsiella, Aerobacter, formerly called Enterobacter, Pseudomonas. I'll try to throw out some other names. Legionella is a gram-negative. Serratia is a gram-negative. Helicobacter, technically, is a gram-negative. Salmonella is a gram-negative. So just keep this in mind, and I really don't intend to going over the exact spectrum of diseases and pathology for each bacteria, because it's not the purpose of this course. It's just to categorize types of bacterial diseases into general groups. Let's talk about the bacteria now, which do not stain easily by the gram stain. And they're called mycobacteria. And they can be cultured, but they don't easily stain with the gram stain. And of course, the mother of all mycobacterial diseases worldwide is, what was probably and still may become one of the biggest worldwide killers is tuberculosis. So often the term TB and mycobacteria are used interchangeably. Sometimes the term acid-fast bacteria or the bacteria which stain with the Zeal-Nielsen method are grouped in the same category. But as tuberculosis leads the top of the list of the acid-fast bacteria, or the bacteria which do not stain with the gram stain, but the acid-fast stain or Zeal-Nielsen stain, as well as a wide variety of other immunologic diagnostic methods. We have this list of non-tuberculosis acid-fast bacteria causing a wide variety of pulmonary and skin infections. And they're the so-called atypical mycobacteria. And there's a bunch of them. And I'm not going to go through the litany of all of them, but the one that's probably mentioned the most commonly now, especially because it's so common in AIDS patients, is MAC, M-A-C, Mycobacterium avium intercellulare complex. And if you're an AIDS patient or you know somebody who's an AIDS patient, you all know what MAC is. And you have to remember that leprosy is also an acid-fast bacillus. It's not in this category as atypical mycobacteria, but it's another one. So TB, atypical mycobacteria, leprosy, these are all acid-fast bacilli. And what else do they have in common? Well, like the fungi, their pattern of cellular inflammation is chiefly granulomatous. So whether you're looking at a fungus or an acid-fast bacillus or TB or leprosy, the type of inflammation associated with it, no matter where you are, lung, skin, bone, wherever they infect, is granulomatous. And the classical types of granulomas are clusters of histiocytes, some of which contain multinucleated giant cells like you see here. And here's a bigger view of a giant cell. And if the center of that granulomatous nodule is necrotic, or you can't make out cellular outlines, those are called caseating. So in here you can still see cells or histiocytes or macrophages, if you will, in the center and the majority of the granuloma. That's non-caseating. But some of them outgrow their blood supply, they become necrotic, and the term caseation is used. And of course, on these three items here, this could be any organism that causes granulomatous. It could be any acid-fast bacilli. It could be any fungus. But if you do a stain on these granulomas, and you can see the Zeal-Nielsen stain or the acid-fast stain, you can see there's clusters of red rods, and these are acid-fast bacilli. And here I think I have a closer-up picture of one. Here's one individual acid-fast bacillus here. In this case, it happens to be an atypical acid-fast bacilli or bacillus of MAC. But could it be leprosy? Sure. Could it be TB? Sure. Could it be another type of acid-fast bacillus? Absolutely. So let's move on now to the other type of bacteria called spirochetes, which don't stain with the gram stain easily, and they don't stain with the acid-fast stain, but they can be seen directly under a microscopic technique known as dark field. And of course, syphilis heads the list of spirochetal diseases. But you should also be familiar or aware that there is another type of spirochete. They all look the same. They all have these little spirals. There are two other common spirochetal diseases. One of them is called yaws, Y-A-W-S. The other one is called pinta, P-I-N-T-A, you know, like one of Columbus's ships. And they're also caused by spirochetes of different species. Syphilis is classically caused by Treponema pallidum. Yaws is classically caused by Treponema pertenue. And of course, pinta, even though it's very, very much related to the Treponema pallidum in many ways, it still has a different name. It's called Treponema keratoeum is the causative agent. In addition, you know, the two tick-borne spirochetal diseases, of one of which you've heard of a lot of already, Lyme disease, caused by a tick, are caused by spirochetes not in the Treponema family, but in the Borrelia family. So a disease called relapsing fever is caused by a treponeme called, there's a bunch of them, but one of them is, we'll just call these borrelial infections. And of course, Lyme disease is another tick-borne spirochetal infection, and that's caused by a specific genus and species of spirochete called Borrelia burgdorferi. Okay, so much for the rundown on the spirochetes, and perhaps we can just say a word about syphilis before we go into the next clip. No, actually, I think I want to end here because I want to spend a little bit more time on syphilis. Thank you very much. Syphilis is worth mentioning in a little bit more detail. Syphilis used to be a rampant wide killer, very popular, very important worldwide. It seems like we had it on the run with penicillin, and then when the AIDS epidemic came back, it came back as well. You may not ever see a case of syphilis, but it's worth to just run it down quickly. There's 3 types of syphilis, and a 4th, if you want to add congenital to the list. There is the primary lesion of syphilis called a chancre. It is a painless vesicle which often ulcerates a little bit. It has very little real significant inflammation around it. That's the one that appears within a week or two after the mucosal exposure. So because it's a sexually transmitted disease, it could be on oral, it could be genital. They all look the same in terms of the chancre. A painless vesicle. Painless, remember that. That goes away. If it's untreated, at some point after that, months, weeks, perhaps years, there's a variety of skin manifestations. The number and types of skin manifestations are so numerous that you just can't classify them. The journal, which for many years was the leading dermatology journal, was called the Journal of Dermatology and Syphilology, because the spectrum of dermatologic changes in syphilis was about the spectrum of all of the dermatologic changes in skin disease in general. Well, that can go on for many years. And then disappear and come and go. The third and final stage, which doesn't get any worse, is the tertiary stage. And the tertiary stage of syphilis is characterized by granulomatous types of lesions, which are called gummas. They're not called granulomas. They could be similar to it, but they're localized necrotic lesions. You can see them in the brain. You can see them in the bone. You can see them just about anywhere. And that's the tertiary lesion. And if you hear the word, I can't think of any other disease in which the word gumma is used except for syphilis. So if you hear somebody has gummas, you know what disease they're talking about. You could be born with it, and there's a variety of characteristic appearances for babies that are born with syphilis as well. The most common of which is what they call the saber shins, or bowing of the tibia, the bowing of the tibia crest. And the thing I want to mention from a histopathologic point of view, but I'm not going to show you a picture, but often the cellular reaction to syphilis, whether it's primary or secondary, not the tertiary, but primary and secondary, is you'll see collections of plasma cells as being the primary cell of reaction to these lesions, rather than neutrophils or lymphocytes or macrophages. So a localized skin plasmacytic inflammatory infiltrate could very well be some primary or secondary stage of syphilis. The anaerobic bacteria are called that way simply because they don't need oxygen to grow. They could be gram-positive, technically gram-negative, but in reality, most of the anaerobic infections which generate gas, and so often they're called gas gangrene, are caused by gram-positive bacilli, and most of the time it's Clostridium. And specifically, most of the time, it's Clostridium perfringens. So if you hear of a patient that has a gas gangrene, you can probably think instantly that's most likely statistically due to a gram-positive bacillus or Clostridium, which we mentioned before, and specifically the most common genus and species would be Clostridium perfringens. Okay, let's go into a little bit more detail now about the so-called obligate intracellular bacteria. Technically they're bacteria, but they can't be cultured. They don't have ATP, they don't have mitochondria, but like bacteria, they could cause a wide variety of infections. The three most common obligate intracellular bacteria worldwide are chlamydia, rickettsia, and mycoplasma. These are all obligate intracellular bacteria. Chlamydia is a very, very common cause of blindness. I'm not sure if it's the most common cause, but it's very worldwide. It's near the top of the list as causing blindness by virtue of the fact that it caused a very significant conjunctivitis. It's also a very, very common cause of urethritis in women as well as in men, and has a prevalence that's probably approaching that of gonococcus in terms of being a specific agent to cause urethritis. Another chlamydial infection is a rare venereal disease called LGV, or lymphogranuloma venereum, but all of these are chlamydial infections. The rickettsial obligate intracellular bacteria are the causative agents of Rocky Mountain spotted fever, transmitted by the tick called Dermacentor andersoni, and they also are the cause of a disease called typhus. The pattern of inflammation in rickettsial diseases, especially Rocky Mountain spotted fever, is primarily a vasculitis. And of course, the mycoplasma are an extremely important and common cause of pneumonias, the community-acquired pneumonias. And if you took a list of all the bacteria that are causing pneumonia in the community rather than in the hospital, mycoplasma is always in the top three or top four. Here is a very, very, very significant conjunctivitis. This is trachoma. This is caused by Chlamydia trachomatis. Here is an image of the vasculitis of Rocky Mountain spotted fever caused by the Rickettsia prowazekii, transmitted by the tick Dermacentor andersoni. And I don't think we'll say anything more about the obligate intracellular bacteria as general classes of infectious pathogens. I think now we'll move on to the fungi, and let's open the door to the fungi a little bit and remind you that fungal diseases, fungal infections, are classified both clinically on the basis of whether they infect only the skin and superficial tissues, so they're called the superficial fungi, and they're also, or whether they're deep, and by deep they could mean anything, but they usually mean pulmonary. Another way to classify fungal infections is whether the organisms themselves, which are easily identified in tissues with either routine or special stains, are forming little balls called yeasts, or whether they have these little branch-like structures called hyphae. So that's a two-dimensional way of classifying fungi: superficial or deep, or yeasts versus molds, and the molds, of course, are hyphae. Let's, as long as we're making good time, let's talk about Candida albicans as being the single most overwhelming common yeast infection, usually in immunocompromised hosts, often in diabetics, and usually in squamous mucosas that are non-keratinized, like vagina, like esophagus, like oral cavity. If you go back to histology and look at your non-keratinized stratified squamous mucosa that's moist, that's where Candida appears, both normally as well as overgrowth and infections. Another type of yeast that's very common, in this case it's deep because it's a very common cause of meningitis in immunocompromised hosts, is Cryptococcus. And that's very, very easily identified by in the lab by putting a little bit of India ink on the spinal fluid, and they really, really stand out very nicely. Technically, any fungus which forms branches is a mold, or hyphae as we say, and the two most common types of mold infections, also usually in immunocompromised hosts, as most fungi are Aspergillus and mucormycosis. Now, the last thing I want to say before we cut off this last clip is that, like the acid-fast bacilli, the pattern of cellular reaction to most fungal infections is granulomatous. Okay, we'll close the door there and start with number 91. Thank you very much. Okay, I think I'd like to make a outrageously exaggerated statement here for a specific reason, because we're going to talk about now about a fungus which, I don't know the exact statistics, but I would imagine that well over 90% of all common fungal infections in humans are probably caused by this one specific species here, Candida albicans. And it has a propensity for moist, non-keratinized stratified squamous mucosa, like esophagus, like vagina, like oral cavity. And it also has a propensity, like most fungi in general, for immunocompromised hosts. And they don't have to be severely immunocompromised. I mean, diabetic patients, which have a variety of reasons for being somewhat immunocompromised, are loaded with Candida. HIV patients are loaded with Candida. Candida esophagitis used to be one of the major diagnostic criteria to differentiate HIV positivity from full-blown AIDS. So I cannot exaggerate too much the importance of this one particular fungus. And the statement I was going to make is, I bet you that this is probably 10 times more common than all the rest of the fungi put together. Diagnostically and microbiologically, Candida albicans is primarily a fungus. Here you can see is primarily a yeast fungus. Here you could see a whole bunch of yeast forms. Up here you could see one that has a bud on it. Usually when you see two of these little blue balls and one smaller, that's probably a bud. Now, these little yeasts can actually start growing and to form these little hyphae. And I put the word hyphae, or preface it by the word pseudo-hyphae, because the microbiologists will tell you they are not true hyphae, they don't have septa, but nevertheless they grow like branches, so we can call them hyphae. So Candida is primarily a superficial fungus with both a yeast as well as a hyphal form, but if it's severe enough, it could form deep infections as well. And another very, very common type of yeast, which is usually a lot more serious than Candida, is Cryptococcus. And Cryptococcus is a yeast, and it can characteristically form deep and even meningeal infections. So it is not the single most common cause of a meningitis, but it's the single most fungal cause of a meningitis. And the reason why I'm showing you this picture here is because it is a yeast. Sometimes it can have a bud, but the capsule is structured in such a way, I forget what the exact biochemistry is, that it repels the India ink particles. So if you are going to order if you do a lumbar puncture and send to the lab, most likely, no matter what this patient has, he's probably going to get an India ink prep. So they'll just take you could do it yourself in your own lab, a little bit of India ink, put into the spinal fluid, and if there's Cryptococcus there, it's going to the organism is going to really repel the particles. So these little things stand out like a sore thumb, and that's without even doing any stain at all. And this is the India ink prep of CSF, cerebrospinal fluid, that shows Cryptococcus. And I guarantee you'll all see that in the lab one time or another, because every now and then that pops up. And if it does, chances are this patient has had some type of malignancy, and they've been under immunosuppressives, or they're immunosuppressed for other reasons. The molds now, or the hyphal structures that are very common in immunocompromised patients, I could think of two that are always at the top of the list. One of them is aspergillus, and one of them is mucormycosis. And they can infect skin and soft tissues, but they can also be infect deep tissues as well. I'll never forget a case of an aspergillus endocarditis that I had in an immunosuppressed patient. And zygomycosis, formerly called mucormycosis or lumpy jaw, is a very common cause of fungal skin and soft tissue infections involving the maxilla. And you'll always see a picture like this showing a bizarre, unusual, extreme case of mucormycosis, more politically correct now called zygomycosis. Okay, let's talk about the classical superficial fungi. By superficial fungi, we're talking about dermatophytes, basically skin and the immediate underlying tissues. The term taenial, T-I-N-E-A-L, or taenias in generally, is referred to as the dermatophyte superficial skin fungi. And remember, taenia is strictly a word meaning superficial skin infection. The actual genus or genera of fungi which cause taenial infections are almost always one of these three: epidermophyton, microsporum, or trichophyton. So if you have a superficial fungal infection of the skin and you wind up identifying it, sending it for culture or whatever, it's going to wind up coming back as one of these three things. Often the taenias grow in a circular fashion, so that's how they get the name ringworm. You can have ringworm of the scalp. You could have a superficial infection involving the beard area, or what they call taenia barbae. You can have ringworm or a superficial fungal infections involving the torso or extremities, or ringworm of the body. This is also another taenial infection. Another common place to have a taenial infection is in the groin area, or taenia cruris, common name jock itch. You can get a taenial or superficial skin infection in the areas between the toes, or taenia pedis or pedis, otherwise known as athlete's foot. And technically, you may have had it or seen it. It's very, very common, but for some reason, it's always the most common between the last toe and the second to the last toe. But technically, it could be in any of these areas between the toes. And last but not least, the tinea infection of the nails doesn't have the word tinea at all in it. It's generally known as onychomycosis, onychomycosis. So it's basically the same type of organisms that are causing tinea infections of the skin, but when they involve the nail, they're no longer called teneas like the skin ones are. They're called onychomycosis. And that's a rundown, 5-minute rundown of the tinea infections of the skin and nails. What about the fungi that aren't superficial? What about the ones that infect the deep tissues, and particularly, most likely, the lungs? Well, those are the deep fungi. And there's a bunch, but we're going to talk about the 3 most common ones. In fact, the histoplasmosis, blastomycosis, and coccidiomycosis are generally always lumped together in the same term to talk about the deep or often pulmonary fungal infections. And they're completely different fungi. A couple of them look a lot like each other, like blastomycosis and coccidiomycosis, because they're both yeast. They both form these little balls. I think coccidio is a little bit bigger than blasto, as you can see here. Histoplasmosis is a much smaller organism, and it forms little granules inside of macrophages, which you could barely see on regular microscopy. But I would like to reassure you that if you do special fungal stains for these organisms, either a silver stain or what they call a PAS stain, per-iodic acid shift, which are commonly done in the lab, these things really stand out very, very nicely. We'll talk more about these fungi when we get to the chapter on lung, because the deep fungi pulmonary infections are also often categorized as the chronic type pneumonias as well. The thing to remember about them the most is that they all mimic TB. Clinically, morphologically, they're all granulomas. They tend to calcify in the lung. So deep fungal infections are usually these 3. They're often pulmonary, and they all can be confused with TB, and I thank you very much. The 3 main deep fungal infections, often called chronic pneumonias, are almost always just rattled off as histoplasmosis, blastomycosis, coccidiomycosis. Both blastomycosis and coccidiomycosis have nice little balls or yeast within cells, which are about the size of a nucleus. They're pretty big. But I want to show you the differentiation now of the first one, which is called histoplasmosis. And the reason why I particularly like this picture. It was taken by a friend of mine, and it's so superior to anything I've ever seen in any of the textbooks. All of these cells here are macrophages. Call them histiocytes, if you will. Macrophage is probably the better name. You see all these little purple granules in them, how small they are compared to the nucleus? These are all individual organisms of histoplasmosis. The genus and species is Histoplasma capsulatum. All of the deep fungal diseases have characteristic differences in epidemiology and morphology and even clinical expressions, even though they all look a lot like TB clinically. I just wanted to show you that from a differentiation of the microscopic morphology, histoplasma is so very, very much different from the other 2. In the other 2, you have big round balls that are about the size of the nucleus. Up here you have tiny little cytoplasmic structures that are about 1,000th as big as a nucleus. Okay, let's move into our last, second to the last group of infectious agents, which we'll spend a little more time in classifying. The protozoans, the single-celled kingdom. I guess it's a kingdom or a subkingdom. And there's about 5 or 6 or 7 maybe common protozoal diseases, and without a doubt malaria is by far the most clinically important. By far, still one of the big top worldwide killers. The species name is Plasmodium. The genus name is Plasmodium. There are 4 main human species. Falciparum is always the most serious and the one that's most likely to be resistant. And we'll get into that life cycle in the next picture, but I wanted to mention a couple of others quickly. You'll probably never see them. You should generally know about them a little bit. Babesiosis is transmitted by a deer tick, not a mosquito, which malaria is, but it has remarkable similarities to malaria, both morphologically and clinically. The big difference is it's very, very rare in humans. You should probably know about it. I don't think you'll ever see a case. There is another protozoal disease, now not involving blood so much as cutaneous and visceral. So there are both cutaneous and visceral varieties of leishmaniasis. And like the other two, there's a vector. In this case, it's a sandfly, just like the deer tick was for babesiosis, and the Anopheles mosquito was for malaria. And in leishmaniasis, it's a sandfly, and it causes a wide variety of diseases involving skin, and the deeper, more serious ones in the viscera. Sleeping sickness, the common sleeping sickness, also a protozoal disease, also a blood protozoal disease. It can be confused a little bit with malaria because you could find these little critters near or on or by blood cells, and that's trypanosomiasis. There's the classical version of trypanosomiasis caused by the tsetse fly in Africa, as well as a South American variant of trypanosomiasis, which is not called sleeping sickness, is called Chagas disease, Chagas. So the common differential of trypanosome diseases is trypanosomiasis in Africa and Chagas disease in South America. Last but not least, we can't forget the amoebas. The amoebas are a common cause of colon infections, diarrheal infections, large bowel infections. The causative agent is usually Entamoeba histolytica. So an Entamoeba histolytica infection or amoebiasis is usually a colitis, but you have to remember that they can also wind up forming abscesses in various places, of which liver is the most common site. Okay, I hope that wasn't too bad of a rundown of the protozoal diseases in general. I think we have to say a couple more words about malaria. That's about as close as you'll ever get to an Anopheles species mosquito. There's really not much that really differentiates it that much from any other looking mosquito, unless you really go to the taxonomy books and look at all the features, which I don't even know what they are. But that's basically the vector. That's where the sexual cycle of the organism takes place, the Plasmodium species, and in man it's the asexual cycle, like it is with many of the protozoal and parasitic infections in general. The human has the asexual phase of the cycle. The mosquito has the sexual phase. And I guess a good place to start would probably be when the Anopheles mosquito bites you. When he bites you, he releases sporozoites, which has developed inside of him or her, because as you know, it's only the female mosquito that can infect you. Those sporozoites are then transported through the blood to the liver, and they develop in liver cells or hepatocytes and release tiny structures called merozoites. These merozoites go through a variety of stages inside of red blood cells now, which are eventually released as gametocytes, both male and female. These gametocytes are then picked up by the mosquito again when he does his thing, and they develop now in a sexual stage involving fertilization, zygote, meiosis, eventually developing these oocysts again, which release the sporozoites. And that's the life cycle of Plasmodium. There's 4 species, and we'll talk about them a little bit because in the lab we always have fun trying to figure out which one is which. But no matter what species you're dealing with, even in regular blood smells or ones that are stained slightly more specifically for malaria, you can see these little various stages of the organisms in the red cell. And we'll get into that a little bit now. Here's an absolutely spectacular false color scanning electron micrograph of some red cells being infected by Plasmodium organisms. So, this is classically what malaria might look like in a regular blood film. Here are some various stages of development. Sometimes they use the word schizontz or ring forms or things that might not be, you might not remember or need to know very much, but the end result, the final thing that's released here is a gametocyte. And because Plasmodium falciparum is without a doubt the most serious and clinically important and the one that's most likely to be resistant to common anti-malarial drugs, just remember that the only gametocyte that is shaped like this sausage is seen in Plasmodium falciparum. Having said that, let's run down some of the 4 different patterns, hopefully quickly. Plasmodium falciparum starts out with a cell that's normal. What's in it infected, it can show a little slight marginal structure. They then develop into ring forms. Sometimes you could see a few little dots, but the ring forms generally develop into trophozoites. The trophozoites eventually develop into schizonts, schizont, and then the schizonts will eventually develop into a mature gametocyte, either female or male. And those are the things that are released back into this critter's nose here, the Anopheles mosquito. Remember, the diagnostic feature, if you want to know this, you may, I hate to say this, but they could very well put this on the board, is that when you see a blood cell that has a little malaria hot dog inside of it, this is only seen in falciparum. It's not seen in the other types. That's one of the distinguishing features. Another type of malaria, Plasmodium vivax, goes through the same sequence of ring forms, trophozoites, schizonts, but look, the gametocytes are not sausage-shaped. In addition, both Plasmodium vivax as well as Plasmodium ovale have these real bright red dots in the cell called Schuffner's dots. Only vivax and ovale have this. Falciparum and malariae do not. And speaking of malariae, here's another type. You go from ring form to schizont to gametocyte. And in the last form, you have the same thing. You're going from, ovale, you're going from ring forms to schizonts to gametocytes. And of course, like vivax, they also have the Schuffner's dot. So is it easy to get ovale confused with vivax? Probably is on a regular smear. But once again, you normally don't have to go in your setting and try to figure out what species it is. All you have to do is look at who, what was endemic to the area. The second to the last type of protozoal disease we'll talk about of tremendous worldwide importance, particularly in Africa, is trypanosomiasis, another protozoan infecting blood, having more of a squiggly and extracellular configuration. Sleeping sickness, caused by the bite of the tsetse fly. Here he is with a scanning electron micrograph, false color, and here he has a nice close-up pictures. There's really nothing bizarrely unique about looking at these flies. They just look like big flies. But remember, the other type of trypanosomiasis is in South America, and for some reason that's just not called trypanosomiasis, even though it's caused by a trypanosome. That's called Chagas disease. And last but not least, I think we just ran over time. Thank you very much. Well, I'm very happy to get to this slide because it's the last slide, and this has been without a doubt the longest chapter. I don't think any other chapter of our 29 chapters will be as long as 18 clips. Perhaps the GI, systemic, or the central nervous system chapter will be as long, but this has been a hell of a chapter, and I felt a little frustrated in that I could not go into all of these individual organisms in more detail. So that's that. I'm sorry. I think this one might be a good time to review our basic taxonomy, and remember that technically a metazoan is any member of the animal kingdom that has more than one cell. So there's two kinds of animals. There's protozoans and there's metazoans. Protozoans have one cell, metazoans have multiple, more than one. So that includes us technically, doesn't it? But in terms of practical parasitology, the metazoans are the worms. And going back to taxonomy again, if you remember, there's three kinds of worms, three phylum of worms. The roundworms, which are round, the flatworms, which are flat, and then the kind of worms we see in our garden, which are called annelids. But as far as I know, the annelid worms, which are the highest developed segmented worms, don't really cause any human infections. I might be wrong, but basically it's roundworms and flatworms. And the roundworms are the nematodes, and the flatworms are the trematodes. So, with the exception of the tapeworms, which we've already went into in terms of the beef tapeworm, the pork tapeworm, the fish tapeworm, and of course the most common tapeworm in the United States called the dwarf tapeworm. All the rest of these things we'll finish up now are roundworms, are the roundworm metazoans. It wouldn't be fair if I just didn't mention that there's a couple of other roundworm parasites that are worth mentioning, so we'll mention them. Strongyloides stercoralis species usually. The strongyloides worms are roundworms. They basically are inhabitants of your small bowel. You pick them up by walking on grass barefoot, where the worms actually can get into your skin through maybe small cracks or lesions, and they can cause a local infection or itching, and eventually they wind up setting shop in your intestine and living there, and usually asymptomatic, but sometimes they could not only be symptomatic but destructive depending on your immune system. So just remember Strongyloides stercoralis, also known as the thread worm. We've talked about the tapeworms, the flatworms, so let's move on to trichinosis. Trichinosis, as you know, in the United States, is obtained from eating undercooked pork. It's because the larvae of these roundworms live in the skeletal muscle of pigs, and if you don't cook the skeletal muscle, the meat, well enough, you can be infected by the worms. And of course, once they're in humans, they can also infect a human skeletal muscle as well. So that's worth mentioning. Last but not least, two types of roundworms, generally both called flukes, schistosomiasis disease and filariasis disease. Schistosomiasis is not common in this country, but it's common in Asia, Africa, South America. It's a very, very prevalent worldwide disease. I think I heard the statistic that potentially 1 billion people could be exposed to it, and it infects millions. Also called bilharzia, B-I-L-H-A-R-Z-I-A, or the disease bilharziosis. It's also called snail fever because the snail is the vector of the disease. It winds up having a human infection, which could, of all places, involve bladder infections as well. And the bladder, in the places where schistosomiasis is rampant, responds to the infection by undergoing metaplasia. And that's squamous metaplasia, not transitional or glandular metaplasia, but that squamous metaplasia can then give rise or be the soil for the development of squamous cell cancer of the bladder. So, make a long story short, even though you don't see it in the United States, probably the vast majority of squamous cell carcinomas of the bladder arose in the setting of a previous schistosome infection. And last but not least, we'll talk about filariasis, or filarial worms. These are small worms. The most common species is Wucheria bancrofti. It's a nematode, or a roundworm. And the filarial, or thread-like worm, I believe it's also called threadworm, infects the lymphatics, the dermal lymphatics and other lymphatics of skin and subcutaneous tissue and organs, and as a result, the skin then become very edematous and saggy, or elephant-like. So the term elephantiasis, in its pure form, refers to boggy, droopy, edematous skin, because the lymphatics are all plugged up by the larvae, or these little filarial worms. And I don't think you can pick up a pathology book anywhere and turn to the chapter on infectious disease or parasitology without seeing a guy who has a scrotum going down to his knees or his ankles, and that's because of the tremendous lymphedema due to filariasis. Okay, so, that pretty much finishes the entire chapter on infectious diseases. I think what we have discussed, even though a lot of it wasn't in depth, is things you should generally know or be aware of, or what I would consider common knowledge, or if you don't mind the expression, board knowledge. And I had fun doing this chapter, and I'm looking forward to moving on to the next one. So I thank you very much.